Hi, Dr. Sandeep Gupta, and thank you for providing us with the opportunity to speak to you today. I understand that you're a general practitioner that specialises in biotoxin-related illnesses and that your clinic is based in the Sunshine Coast in Queensland, and that you are the founder of the Mould Illness Made Simple course, which was recently upgraded to the second version. Thanks for having the time to talk to us. What I wanted to do is to the purpose of this video is to enable building biologists and mold testing technicians to understand the process of what happens when people like us identify clients who potentially could have chronic inflammatory response syndrome, and we need to refer them to a specialist GP like yourself. So that's what I'm hoping to get out of this particular video. So can you take us through the process? You've got a patient in front of you who suspects they have SIRS. What is the procedure that you undertake to be able to diagnose that?
Yeah, sure. So let's go a little bit into this, and so I guess it must be fairly overwhelming already to just have to assess a house and you know do a thorough history with a family about the history of that home or building, and then to start thinking about their health and how it might be impacting their health is a whole other area. And so if we had a client come to us who is suspected of having mold related illness, uh, one of the big things we do is just take a very thorough history. And in some cases, that can involve questionnaires, or it can just include very targeted questions relating to the onset of their symptoms and all of the different symptoms and the severity and also any correlation between the symptoms and any environmental exposures. And so when it comes to mold and water damage buildings, a classic sort of thing would be we would be asking people, let's say they were suffering from chronic fatigue, or that's what they had been diagnosed with up until now. That, for instance, the fatigue, let's say that's their major symptom. When exactly did that start, and were there any major times where it either became better or became worse again? And then at that time, what sort of home were they living in? And was there any obvious signs of water damage to those buildings at the time? And so, as you guys know, it's not always that easy to draw that out of people, but we'd try our best to just try and get them to think about, was that home have any history of leaks? Was there any signs visually or in terms of the smell or in terms of places that they in the house where they just didn't want to go to, or the age of the house, etc., and see if there's any little clues there towards water damage, and try and really kind of create a really good timeline in terms of when they were ill and how that corresponded to where they were living. And then, when we look at symptoms, one of the things is just to work out whether they're fairly localized symptoms. So that could occur with someone who had more of a mold allergy, for instance, that they could just get localized symptoms in the nose or throat, something like that. Let's say they just got an itchy throat and they have a runny nose and they get some sneezing and so on. That could be like mold allergy, which is what most doctors are more familiar with. But when they have what we call CIRS, which is a term that was invented by Dr. Richie Shoemaker, we're really talking about a whole body process. And they won't just have an itchy nose and a scratchy throat. They'll have a whole range of symptoms. So if they've got fatigue, it won't just be fatigue. It'll also be, they'll often have anxiety. They'll often have insomnia. They'll often have some kind of gut symptoms. They will often have some type of skin rashes. And so it really affects the whole of the body because it's not a localized problem. It's a whole body inflammatory problem. We often say it's like the body on fire. So we call it inflammation. So what's happened is that it's not just the localized effect of the mold. Again, it's actually the mold has actually triggered a whole body inflammation process, and that was thought to be just related to people's genetics primarily, related to what's known as the HLA genes. And the more we're looking at that, we think that there's probably a broader way of understanding this. Is probably not just as simple as genetics, but that's still a reasonable way of understanding things, that there's certain people who are more genetically or emotionally or physically predisposed to having this illness than others. So
What proportion of the population do you believe? For example, with Richie's work, he was stating about 24%. Do you agree with that?
We don't know the exact number. Actually, with the more recent research, when we've looked at the HLA types, is that we find that they're much more common than he was stating. Like, he was looking at international gene registries, and so it looks like in Caucasian populations, it may be more like 50 or even 75% actually have those genes he was talking about. But when you look at all the different susceptibilities and so on, it probably is somewhere around that, somewhere around a quarter to a fifth, roughly, of the population. So classic thing would be, I had an experience where there was a clothes shop in Newcastle or somewhere, became massively water damaged through a storm. And some people were mildly affected, but there was a couple of people who were really, really affected in terms of developing a whole body inflammatory process. And I think there was 8 or 10 staff there. So I think that roughly equates to around 1 in 4 or 1 in 5. So that's what we see. Some people are definitely more predisposed to it than others. Probably that's probably the simple take home there. And those people just get a much more severe illness than others. So my ex-partner, for instance, when we had a house flood, she was much more affected than I was, and was virtually bedbound, while I was just noticing a slight decrease in energy levels. So some people get very, very affected, and so really those are the people who, and the problem is, I guess, with just referring them to a standard general practitioner, is often there hasn't been training in this area of environmentally acquired illness. And so if someone really presents with something that has so many symptoms as that, like what I mentioned before, maybe they have headaches, maybe they have fatigue, anxiety, abdominal pains, they might look at a few basic, conditions, so like what we call autoimmune disease or connective tissue disease, and exclude those with some blood tests. That would be quite standard. But if they then find the blood tests are normal, it would be quite common for them to kind of jump on the idea of anxiety and depression being the explanation. And I think the reason for this is we haven't really been trained in this category of illnesses, where people develop a multi-system, multi-symptom illness due to environmental exposures. And we've been taught more or less in our training that, that if something's that widespread, well, if it's not lupus or rheumatoid or something like that, which is they're examples of autoimmune disease, then it's likely that it's just going to be anxiety or something psychiatric. And so it's a little bit of an outdated training, unfortunately, but that's really how things are. And that's really why it is quite important, in my opinion, to refer people to someone who's had special training in this area of environmentally acquired illness.
You mentioned autoimmune disorders. What proportion of patients that you see have been previously diagnosed with an autoimmune disorder before they see you? I say that because I've seen quite a number of women whose houses have conducted an assessment in water damaged buildings who've been diagnosed with multiple sclerosis, which to me doesn't seem to be MS, but the symptoms are very similar to chronic inflammatory response.
Yeah, so I haven't done a statistical analysis of that, but it's actually quite common. Particularly, the commonest one is Hashimoto's thyroiditis. That's extremely common, and it seems like when people get bad enough inflammation, the thyroid will tend to be the first thing that tends to get a bit of autoimmunity against it. It's a very, very sensitive organ. The other thing that often then gets elevated is what's called the anti-nuclear antibodies, which are just cellular antibodies, and that can go all the way to causing a lupus-like illness. Sometimes you can get rheumatoid arthritis. That's often when there's parasites or tick-borne illness involved as well.
Mm.
And then sometimes you get neurological syndromes such as multiple sclerosis. Often there will be tick-borne infections involved as well, in my experience. So autoimmune's quite common, and CRS can actually be complicated by autoimmune disease. So I think it's important. That's an important point, that they're not totally separate. And I think anyone who's got CRS should have some screening to make sure they don't have autoimmune transformation going on as well.
Which begs the question, which came first, the chicken or the egg? Was it the fungal particulate, or what a chemical stew, or what happens in a water damage building that elicited the symptoms? I think that's the interesting thing in the case history, isn't it? Is the history and timing of exposure becomes so important, and correlating that to what was going on in their life, tick-borne illnesses, blue-green algae outbreaks, water damage buildings, and the time they moved in or renovated is an important part of that. Now, you mentioned several things in relation to predisposition, such as the HLA and genetic predisposition. You also mentioned history to water damage buildings. We've noticed a lot as building biologists that it's really rare when we're taking a history, an environmental exposure history, that this is the first time they've been exposed to a water damage building. Without fail, most of the patients that I've seen have had multiple exposures to multiple water damage buildings, especially in childhood, which seemed to result in an increase in this threshold that finally they reach that, and then their symptoms, their health declines significantly. What is your what have you found in relation to that? Like you mentioned, ticks. Do a lot of them come in with tick allergy or tick exposure, and then water damage buildings, etc.? Is that really common in the case histories that you're finding?
Okay, that's a multi-barreled question, but I think the way of approaching it is that yes, people often have multiple exposures, not one. It's not as simple as as persons had a moldy house, then they were totally well, then they got sick, and that's the end of it. It's often more complex than that, and as you say, there often has been multiple water damage building exposures throughout their lifetime, and I believe it's like a threshold situation. So if you drew a line of it, it may be that someone has a certain amount of mold exposure and then is okay for a little while, then they have a subsequent one, and it may be that they hit a certain threshold. Dr. Shoemaker's explanation was there has to be some kind of cytokine storm take place, and he calls that like a gene priming event where their HLA genes all of a sudden are then activated. So just because you have the genes, it doesn't mean that they're actually expressing. So either of those may be an explanation, and it's quite common that someone who has had a tick bite and becomes unwell from tick-borne illness then becomes sensitive to the water damage building that they were living in maybe for many years before without any problems. And so it may be that it's either an accumulation effect, or it's more like an inflammatory storm effect where the tick bite all of a sudden caused an inflammatory storm. Now the HLA genes are reacting against the contamination in their buildings. So yes, I would say that it's very common when you take a thorough environmental history that you get a complex set of environmental exposures that have occurred.
Right. What about in relation to post-traumatic stress disorder? That seems to be coming up a lot now with the amazing amount of mental health issues that has come to the fore in the last couple of years, especially since COVID. Have you noticed that a significant stress event as also being something that could predispose these patients to chronic inflammatory response in the history?
Yeah, it appears so, Nicole. I think we need more research in this area, but it appears that is a significant factor. And when you look at the past histories of people who have CIRS, often there will be emotional trauma in their background. And there's quite a bit of research going on looking at adverse childhood experiences and what effects they have on the body, but we know that it affects the HPA axis, which is an axis that relates to the adrenal glands and the stress response, and we know that it turns on certain genes already. So it would make sense then if really CRS is ultimately about a dysregulation of genes, which is what Dr. Shoemaker is saying, that if there's already been some pre-existing dysregulation of the genes, it's going to be much more likely for someone to have that situation occur where they've got a significant whole body dysregulation of genes going on.
Okay. In relation to the phenotype, what do you see in the physical body that also escalates the possibility that they have CIRS? I notice in Shoemaker's research, he talks about hyperflexibility of the joints. Can you explain a little bit about that, please?
Yeah, so if people have a hypermobility-related syndrome, such as Ehlers-Danlos syndrome, one of the things about that is they tend to have much weaker connective tissue, And so therefore they're much more sensitive to the effect of inflammatory cytokines, and they're much more likely to get something called mast cell activation, which you could say is like a sister syndrome to CIRS. And so they just tend to be a lot more sensitive, in my experience, to water damaged buildings and other chemicals and so on. So that's definitely one. And then if people have already got tick-borne illness, or they've got significant gut problems, that's also, in my experience, appears to weaken the body already, so that its ability to just have a normal immune response against microbes such as mold is going to be impaired. So it's almost like, if you've already sick to a certain degree, there's a lower threshold for you to then become even more sick.
In the research that I published a couple of years ago as part of my PhD on interviewing the top environmental doctors, including yourself, what came up very clear was that people with Scottish or Wales background were far more sensitive to food-related allergies and gut-related disorders. Have you noticed that if people have a genotype of that ancestry, that they are more susceptible? Do you look for that in the case history?
We haven't really done a statistical analysis of that, but there are definitely differences in genes in different parts of the world. So celiac disease is very common in English and Ireland and Wales background, and also what we call the hemochromatosis gene is much more common, which may actually be another minor predisposing gene for CIRS. We're looking into that as well. And then people from Mediterranean origin, they have much more likelihood of having a gene for something called thalassemia, or something called glucose 6-phosphate deficiency. So there's a bunch of different gene types that go with different areas of the world. So it wouldn't surprise me if there was some degree of genetic susceptibility factor to CIRS, although I have seen people from a variety of different nationalities getting this.
In relation to the testing, what sort of tests would you get a patient who you suspect has CIRS in order to confirm that diagnosis?
Yeah, so the classic thing was we used to do what was known as the HLA gene testing. That's become a little less popular, as people like Dr. Neil Nathan have said that it doesn't seem to be as predictive as was previously thought. But you can still do it, and it's generally done with the Sonic group of labs, which is Douglas Andy Moyer and Melbourne Pathology and Sullivan Nicolaides and Clinipath. And you have to ask specifically for the HLA DQDR gene testing, and then they give you a number, which you can then marry up against Dr. Shoemaker's Rosetta Stone. So that was one thing that we used to do. The VCS test is very, very helpful in addition to a thorough history. Again, it's not perfect, but if it's abnormal to start with, that tends to be somewhat predictive, and then it's useful then also as a progress marker. So the VCS stands for visual contrast sensitivity, and it's got to do with their ability to discern fine shades of gray. And it's thought to be related to inflammation, neuroinflammation, which also affects the optic nerve or the eye nerve. So that's very useful, and you can do that in if you've got the kit in your rooms as a doctor or as a naturopath, or do it online at survivingmold.com. And then there is what was called the biomarker testing, the CIRS biomarker testing. That's become much more difficult to access now, but that was classically done with the US labs, Quest and LabCorp. We are looking for another arrangement to have those ones available. And then we have some of the newer testing, which is still being more closely looked at, and that includes the organic acid test, and then the urinary mycotoxin testing, and serum mycotoxin testing, which is now being offered by a couple of laboratories, one in America and one in Germany.
So what is it in those last three tests that have come onto the market, the organic acids test, that you're actually looking for? What are those markers that increase the chances that they have the CIRS?
Yeah, so in the organic acid test, you look at the fungal colonization markers, and that's not specifically for CIRS. That's more for fungal colonization as a separate cause of illness, if you like. So when the mold actually gets into the body and starts living in the body, that can show up. And then the oxalates are very, very important. And then we've got what's called the succinate and the lactate and the pyroglutamate are the main three markers that are looked at. And there's a classic pattern that comes along with those that's quite predictive as well. It's probably just as predictive as the original SIRS biomarkers.
So are they metabolites of as a result of the fungi being in the body, or what are those
Well, the
markers?
first ones are the fungal colonization markers are metabolite type markers, but they're what a lot of them are what we call furan markers, and but the other ones are they're more what we call organic acids that basically build up when certain enzymes aren't working well. And so often the succinic acid and the lactic acid become elevated because the cellular energy production is being affected by the inflammation in the body.
Which naturopaths would refer to as mitochondrial dysfunction or
Yeah,
something like that.
yeah.
Yeah. Mycotoxin testing is something that I'd like you to go into detail because, of course, building biologists and mold testing technicians can do viable sampling. And I'm wondering how useful that is for you as a clinician to see that in their reports from us as to whether it's justified to do viable sampling, say, for example, in the home, to be able to pick up the genre and the species of the fungi and then matching that to mycotoxins in the urine. Tell me about that.
Yeah, so basically urinary mycotoxins. I mean, urine is one of the excretion routes of mycotoxins, but it's actually a lesser one compared to the liver and bile and feces route. So it is, however, an important one. And so, some of the original research suggested that 98% of chronic fatigue patients had mycotoxins in their urine and 0% in normal controls. That was the original study done by Joseph Brewer and his set of colleagues. I think later it was found that there were some problems with that study, and that doesn't really marry up to everyday experience. It does appear that actually it's very common to have mycotoxins in your urine. And so I think some more recent research by Great Plains Laboratory said maybe it's 50% of controls and 80% of people who are unwell. So that takes a little bit away from this idea that, if someone's got mycotoxins in their urine, that you just go, hallelujah, we found it. This is the end of it. It's not that black and white, actually, we've been finding. And so there's 3 different laboratories who are doing the testing. One is called Great Plains, as I mentioned, and then the carriers for them are RN Labs and Australian Biologics. And then we've got real-time laboratories, which are being offered by Nutripath. And then we've got Vibrant Laboratories, which I believe are just a new kid on the block, and they are now offering their testing to Australia. There's slightly different technology. The second one with the real-time laboratories uses what's called ELISA technology, and so does the Vibrant, if I'm not mistaken. While the Great Plains laboratory uses what's called mass spectrometry, liquid chromatography. So it's quite different. And so they tend to be a lot more sensitive. The Great Plains probably picks up small mycotoxins better, like particularly ochratoxin A. However, it won't tend to pick up mycotoxins such as aflatoxin and trichothecenes, as well as the real-time laboratories will. So people like Dr. Neil Nathan are now saying, well, you have to do at least 2 of these. You don't really get a picture with doing one, and I'd agree that with that doing one is really not that worth it, particularly Great Plains. And so it probably leads you invariably to the answer that people have a range of different mycotoxins going on. And generally speaking, you need to use a range of different binders to cover them. And so I'm not necessarily finding that doing that testing really makes much difference over just saying, well, let's just select a broad spectrum of binders, because also it's only showing what's being excreted at that time, and there's no guarantee that there's not other mycotoxins in the system that are just not being released at that point. So I'm not necessarily convinced that you get much more accuracy by testing the urine than just selecting a broad range of mycotoxins as being likely to be there. So yeah, with regard to marrying it up with air samples, you certainly can try, but it won't marry up in every case, in my understanding. And there are published studies by Jack Thrasher and so on where he did have a case where there did seem to be good correlation between mold species found. I think that was on air testing and then the mycotoxins found in the urine.
Mm.
So in some cases it will marry up, but I guess I just want to put that caveat in there that it may not always be as satisfying as you hope.
No, and that's a good point, because mycotoxins are found naturally in grains, coffee.
Yeah,
I
yeah,
mean, 2 coffees a day keeps Nicole at bay, so I'm not stopping that for anything. But obviously, and this is why mycotoxins, I think, would be the majority of the world's population on that basis alone, let alone wheat and other grains, which
yeah,
are often contaminated with fungal particulate, etc.
yeah.
I was just thinking in terms that in water damaged buildings, we have a shift to specific species that are very synonymous for water damaged buildings: Aspergillus penicillium, Stachy, and of course Cladosporium and Ketonium. Many of them are mycotoxin producers, and whether the mycotoxins from those water damaged molds could be seen in patients exposed to those buildings. And that's where, especially if it's going to NCAT or VCAT, that if you're showing correlations that, this building, this rental property is actually the mycotoxins from those molds. It's not very common we're doing legal related issues like that, but I'm just wondering, have you dealt with anything like that where?
Oh yeah, yeah, absolutely. We've dealt with a lot of that. I mean, the way we were dealing with it was having the proper biomarker testing done generally, and that would then generally fit the bill, because that the studies that were done on CIRS were generally of a slightly higher standard. Although there's more coming out now on urinary mycotoxins and so on, but there are still associations like the International Allergy Association, or American College of Allergists rather, who are saying urinary mycotoxin testing should be disregarded and so on. So, can be done, though. You're right. You do need to have causation established more clearly in cases where there's legal proceedings going on. So you generally will need to do more testing, try and establish a link.
Yes. Now, you mentioned early on when we started looking at testing that there were some markers, neuropeptides, that obviously having difficulty getting those tests.
Mhm.
Can you mention some of them, like VOP, MSH, and why they're really important in terms of the diagnosis?
Yeah, so there's a classic pattern of change of biomarkers that occurs with CIRS, and really it's just the classic pattern of the body being affected in that particular inflammatory pattern, and so it includes, as you said, VIP and MSH. They're what we call neuropeptides, and then there's basically what we call inflammatory cytokines, which includes C4A and TGF beta 1 and some other ones, but maybe if we just mention those four for now. And so there's certain markers go up, and that's for the cytokines, which are compounds which fuel the fire of inflammation in the body, and then certain compounds go down, which are neuroregulatory peptides, which should really regulate inflammation in the body. But if they're too low, the body then loses its regulation and is able to continue in an inflammatory state. And it's also much more likely to get different types of infections when you're low in MSH and VIP, because they're actually antibacterial and antifungal and antiviral in some cases. So it's more likely you'll get bugs in your nasal passage and other types of infections in the body.
Mm. And in fact, this is really what the whole inflammatory response comes down to, is that mold is like uncontrolled infections throughout the body that appear to be clogging up many of the pathways, whether it's mitochondrial dysfunction, detoxification, and this has a downstream impact on other parts of the body that results in multiple organs being involved. For example, from the limited exposure histories I've conducted in the last couple of decades with patients, I've noticed that when you take a thorough history, that the symptoms are often, they follow a particular pattern. I'm just wanting to see if you've
Yeah.
noticed this. For example, just from my anecdotal observation, I found patients start to get tired, the sleep then gets disturbed, the fibromyalgia, muscle aches and weaknesses, the brain fog, poor concentration, poor memory, and then they can slip into anxiety, depression, or possibly even psychosis. And it seems to follow this physical to mental route. And
Mhm.
I've noticed that when they're getting the right treatment, they're out of the water damaged building, it goes in the reverse order of symptoms.
Mhm.
Have you noticed anything like that in the years you've been working with patients with these illnesses?
Mhm. First, I just want to go back to the first thing you said there. So, just to clarify between infection and inflammation. So, when we're talking about CIRS, we're not necessarily talking about an infection. We're really just talking about particles or spores or fragments or even bacteria or parasites. There can be all sorts of things that are getting in the body and triggering the cells to then create cytokines because they're unable to produce a proper immune response. And yeah, and so there may not actually be whole mold in the body causing infection or colonization, but if so, then we could say there's a second category of illness going on, which is mold colonization. And then if there's also some allergy as well, then there's a third type of illness going on. So all three can go together, or they can be individual. So then going back to the order, I think there's what you said is actually, I think, a fairly common order where people can develop things. I have seen it happen the other way around in some cases, and I do think it just depends to some degree on where the weakness are, pre-existing weaknesses are in their system. So if they've already got a lot of pre-existing weakness in their neurological system, they may develop anxiety and insomnia quite quickly, for instance. But yeah, I think in most cases, as you say, that's quite a common progression from it becoming more physical to start with, then becoming more mental later on.
Mm. Now, take us through the treatment protocols. What treatment strategies are absolutely critical for patients to get better, that is not compromisable? Because, of course, there's a lot happening in the health space, and natural therapists who are very limited in their capacity, A, to test because they're not a GP, and B, to treat with appropriate treatments. Why is it that, for example, binders, from my understanding, are one of the most important treatments that patients need to help them navigate this illness and to get better or manage their condition? Can you take us through that?
Yeah, sure.
Why are binders so important, and what other treatment strategies are not compromisable that they need to do?
Okay, yeah. So the most important step, and so Dr. Shoemaker had like a 14-step protocol that you went through one at a time, and you were checking biomarkers all the way along and so on. But as time has gone on, and particularly the ICI group of doctors, which is spelled ISEAI, have gradually adapted this and kind of created a more holistic approach to this. But step one is still, I think, the same for everyone, which is get away from exposure to the best degree possible. And so the analogy is that if you're in a leaking or a sinking boat, you can pail the water out, sure, no problem. But if that leak is still going, you're going to sink. There's no two ways about it. And so you've got to patch the leak. That's number one. You've got to stop the person from getting exposed regularly. Otherwise, you think about it, it's just like someone's hitting you on the head with a hammer. Okay, sure, yeah, you take some Panadol, some aspirin, but you've got to stop them hitting you on the head. It's otherwise it's pretty futile. So that's the number one thing. That's the mechanism which is driving this illness, is the contaminated particles from the home coming in and triggering their genes, if you like, and their proteins to create all these abnormal cytokines. So we need to stop that occurring. We need to stop these particles getting into the body. And so that's where you guys are so important, by looking at their home, giving them advice on whether the house is remediable or whether they have to move, and whether it's a problem at all, actually. And once they've done that, and I'm not saying they can't start any treatment until they've done that. Sure, take some Panadol, but make sure you get the guy to stop hitting you on the head.
And
Rather crude analogy, but it makes the point.
yes,
So yeah, sure, you start and then simultaneously you can start the treatment. I know it does take some time for the treatment to work, and for, sorry, I meant to say, it does take some time for people to be able to address their building as well. So while they're doing that, it's fine to start them on binders, and binders are basically supplements or pharmaceutical agents that actually have a binding effect on biotoxins, such as mycotoxins and other compounds. And generally they bind onto them in the bile, and so they basically stay in the gut, and when the bile is excreted by the gallbladder or the liver, the it's then they then come in contact with the gut, and if the gut is coated with binders, then the binder latches onto those to the bile and to those toxins and takes them out of the body into the stool. If those binders aren't there, then generally what happens is the body recirculates these toxins via what's called enterohepatic recirculation, and therefore they're just never really got rid of in a significant way. I mean, a small amount may be coming out through the urine, but it's pretty small.
And I
So,
think that's an important point, because many patients can remain sick being in healthy homes. And in fact, even their cars and workplaces can be contaminated. But being in a healthy home still remain sick because of this recirculation of the biotoxins throughout their body, which is why they need to see a clinician.
yeah, it's very important that they do that. Also, it's quite common that they've also got mold colonization going on, and so yeah, so it is very important to have those things addressed. Otherwise, it's like you've still got a mold factory inside you.
Mm,
So
mm.
yeah.
Now, I noticed there are quite a few binders used by natural therapists. I've had some concerns in relation to some of these binders in relation to other toxic metal exposures inherent in these binders, because some of them are sourced from the ground,
Mhm.
which of course is also a source for other toxic metals, asbestos, whatever, blah, blah, blah.
Yeah.
Um,
Yeah, well, yeah, zeolites are generally aluminosilicates,
mm,
and so they contain aluminium by their very nature. And so whether they disassociate into aluminium is doubted. But yeah, I guess you could say
it's,
that is
yeah,
something to be aware of.
yeah, it's not the aluminium, because it is so tightly bound in the silicates that the aluminium is unusually to be in these present, but it's the other toxic metals that are naturally found in those. Wherever aluminium silicates are found in the ground, they often have other forms of toxic metals that are very commonly found in zeolites, and that concerns me, such
Mhm.
as lead, which is, on testing can come up time and time again. Unless, of course, they get food grade zeolites where they're removing those impurities, I think is important. The other one that I've found at conferences that natural therapists will tend to use are things like chlorella and
Mhm.
seaweed. But in the research, it appears that seaweed is most effective at binding when it's growing. And of course, by the
Mhm.
time it comes in a pharmaceutical tablet, it's not growing, which means
Mhm.
its efficacy is questionable. Um, and the fact that it's so effective that it could have already bound the toxic metals, and then if it's not tested and impurities are removed, that it could actually be a source of toxic metals. So as a result of this, do you use those types of things, or what type of
Yeah,
bind?
to some degree. Yeah, to some degree, using zeolites and chlorella. Um, yeah, so I mean, one of the things is making sure that the brand that you're using is having quite stringent testing done, and so that's really important because, as Nicole says, you got to be sure that these things aren't contaminated to start with. And generally speaking, the most important ones to start with will tend to be cholestyramine or cholesevelam or Welcol or charcoal, because a large part in most cases of the mycotoxin burden is ochratoxin A. And again, same thing with charcoal. You need to be sure of the source. And so we've found a particular source that that we actually offer at our clinic, and use that pharmaceutical grade charcoal as well as those other binders, which are only prescribable by medical practitioners at this point, and that will tend to get things going. And then depending on so generally, if you have a look at the other mycotoxins, in the chart that was created by Beth O'Hara and Emily Gilvler and signed off on by Neil Nathan, they basically, the bentonite clay is one of the ones that will bind a lot of the other mycotoxins that those three don't: the charcoal, cholesevelam, and cholestyramine. So quite often, if you use the combination of something like bentonite clay and charcoal and cholesevelam or cholestyramine, that'll give you a pretty broad pickup in general. And as I say, using something like the Mediclay FX, which is a very well tested form of bentonite clay, is a good idea.
Okay. So I notice a lot of patients probably would have been on prescribed anti-inflammatories as a result of their autoimmune disorders before they come to you. Why is that not a good idea?
Well, yeah. So if you're talking about prednisone and so on, I guess the biggest thing is that they have long-term side effects. So they do suppress the immune system, they do lower bone density, and they can cause gut inflammation as well. I mean, in emergencies, they definitely have their place, but yeah, I mean, long-term use is probably not the ideal way to address this kind of syndrome. So, um, The hope is that by addressing the source of inflammation, if someone is on prednisone or similar compounds due to their autoimmune illness, that their inflammation that's causing this autoimmune problem will reduce, and therefore it's hoped that their dose of prednisone would be able to be significantly reduced.
Right. So what I've heard you say so far in terms of treatment is the first thing is get them out of the environment that's creating the problem, whether it's their contaminated house, car, workplace, whatever. And secondly, to enlist binders. What other treatment protocols do you
Yeah,
find?
so then the next thing is addressing the nasal passages. And so Dr. Shoemaker's team was looking particularly at one bacteria, which they called Marcons, which is a type of staph. And so their treatment revolved around testing for that. Then, if present, using a antibiotic nasal spray. But now they've actually gone away from that and started using a silver and EDTA nasal spray, which is more natural. And so, the ICI group is really looking at it now as in a more holistic way, thinking of really this Marcon's bug as just one of the organisms which can, be part of the overall imbalance of bacteria and fungi in there. And often there's some degree of fungal colonization going on as well, as I said. So really there's a number of different approaches being looked at. The silver can be quite helpful, using also something like biocidin or iodine, and just even regular nasal flushes. That's all very important, but the nasal passage is often very greatly affected. And it's important to do that often before you then go look at the gut biome, which is often very significantly affected as well. And making sure those two areas are closely looked at is extremely important. And so there can be fungal colonization in the gut as well. And so often using herbal antifungals is very important. And in some cases, pharmaceutical antifungals, although we try to keep that to a bare minimum.
Hmm. What about the use of antibiotics in light of the fact that you've got fungal colonization and potential infection from bacteria? Where do you sit with that?
So it's more of a last resort. If it's very, very severe, it can be like, some people you find, I actually had this myself, that there's one lab that looks very closely at strep and enterococcus in the gut versus, then this is the aerobic part of the gut component versus E. coli. And you should have mainly E. coli and hardly any streptococcus. But I had 99.9% streptococcus and zero E. coli. Well, that's pretty severe. And so in that case, I did use antibiotics for a certain while to push down the strep, and then and then give various probiotics and prebiotic foods to bring up the other bugs. So yeah, in a minority of cases, antibiotics are used also for parasites at times. I guess they're antiparasitics. So if people have very severe parasite infection, sometimes antiparasitics are important as well. So it's important to be holistic. In other words, is what I'm getting at. It's not just mold. Often mold is part of a whole conglomeration of factors, and it weakens the body, so they're more likely to get parasites, they're more likely to get dysbiosis. Often they'll have gluten intolerance and other food allergies. Often they'll have small intestinal bacterial overgrowth. So it's really a very holistic treatment program, and it is often several years. I would say that generally people need to be treated for. If they can't do that, they still will often benefit, but really they should look at treating themselves, getting treated for, like, let's say around 3 years
Right.
minimum. And some people decide to go even further after that and even look really closely at their brain and have neuroquant testing done, which is a type of analysis of brain MRI, where they want to try and get rid of any inflammatory changes there, just so as to reduce their risk of Alzheimer's and other neurodegenerative conditions. So if you really want to dot the I's and cross the T's, you may even want to treat for longer than 3 years.
So after 3 years following the treatment protocol, and obviously it's going to be different for different people, providing they can get out of the water damaged environment, what is their level of recovery back to pre-illness? Is that even possible? Can they be
Um,
completely cured?
Yeah, I have seen cases where they appear to be back to 100%, but most cases I would say it's not 100%. I'd say it's somewhere in that 50 to 90% bracket. And it may be just because they've developed such an extreme sensitivity now
Mm.
that they become reactive to all kinds of things that's very hard to get away from. They start to, reacting to even mild levels of mold, which they're not able to get totally away from. And so we are recommending what's called limbic system retraining more and more, such as the Gupta program, which is a short Gupta, the other half of the Gupta empire, and or Annie Hopper's DNRS program, to help them to calm down that whole sensitivity, which generally occurs as part of the whole experience of having mold. Because yeah, that's part of it. There's like a fire alarm in your brain which just goes off all of a sudden, even when there's tiny exposures to mold or chemicals. I was speaking to Alex Stewart the other day, and she said the same thing has happened to her. That all of a sudden she just had a tiny little exposure of a chemical, and her whole body went into a panic response. And so there's been that sensitization go on,
Mm.
where the limbic system of the brain has become acutely sensitive. And so to work on desensitizing that and restoring it to a normal level of sensitivity is also a very important part of recovery. So we are very hopeful if that people do everything, including the limbic system retraining, and including then doing some graduated exercise and various things at the end, that they can get very close to or get to 100% of their
Mm.
pre-morbid state.
And this is where therapies like what you've just mentioned, somatic experience, I've found very useful in
Yeah.
my own life, has
Yeah.
been
Yeah.
fantastic.
So somatic psychotherapy is actually an even deeper type of therapy, where you really get right into the body and release any stored traumatic energies, and release them totally from the body. And that's where you're really starting to talk about deep healing, where this experience with mold really becomes not only an opportunity for you to learn about mold and heal from it, but actually heal yourself deeply, from everything that
Yeah.
you've experienced in your life. So it you could say at one level, probably the way to think about it is your life will probably never be the same again after you've had mold, but it should be a much more aware and conscious and a connected life on every level. So mold illness can be a very great awakener for sure.
Mm. I wanted to mention one thing before we move on to resources and wrap it up. The use of coffee enemas or enemas. Do you recommend that at all?
Yeah, so the thing is with binders is they're only going to work if there's enough bile going on, being excreted into the gut, and in many cases that is a rate limiting step. And so for a lot of people, when you detox, there's just not enough bile around for it to latch onto all the toxins. Coffee enemas very greatly increase the bile excretion of the body. So as I say, they address that rate limiting step in detoxification. All of a sudden, you have much more bile coming out, especially if you're able to hold the coffee enema for 12 minutes or longer. And then all of a sudden, boom, the gallbladder, if you have one, excretes a whole bunch of bile, and then there's heaps of toxins for the binder to latch onto. So it's most recommended to do coffee enemas before you take binders.
As in, you do the coffee enema and then wait how long? Or do you mean do it for a
Well,
period
actually, sorry, it can be the other way around. Try that again. You often would take the binder and you give a bit of time for that to get into the lower gut, and then you do the coffee enema. Sorry, I said that the wrong way around, because you really want your gut to be coated with binders by the time you do the coffee enema. So sorry, the other way around.
as in different times of the day, one in the morning, one at night, for example?
Yeah, you could do it that, but I'm saying binders. Let's say you take a binder at 8 a.m. Depending what your work schedule is, if you can do your coffee enema half an hour after that, that's the most
Oh, okay.
ideal way to do it. But the key is get them in some way or another,
Mm.
because they will greatly help. I mean, if you people would generally notice a significant difference if they're helpful for them, and there's certain people with certain gene types that it's particularly helpful for.
Okay.
Occasional person doesn't tolerate them, but I found that's quite rare.
Mm. Now, I notice infrared saunas is something that's talked a lot about in natural therapies for detoxification of chemicals. What do you see that's any of benefit for patients with biotoxins? Because I notice many of the clients we're dealing with as building biologists are also chemically sensitive. What is
Yeah.
your take on that?
Yeah, there was some research done recently which looked at ochratoxin and saunas, and they did find that there was significant excretion through the sweat route. So we do believe that that will contribute as well, using the skin as an excretion route. and that should contribute to overall detoxification. And the other thing, as you mentioned, chemicals are a thing, heavy metals are a thing. It's also important to note when people have had mold, their detoxification pathways are often blocked, particularly the ones related to glutathione and other antioxidants. And so when, as part of this, they've often got an accumulation of other toxins, including chemicals and heavy metals that also need to be detoxified. So the detoxification aspect is very, very big, and the infection aspect is also very, very significant in many cases. And that I'm not just talking about mold infection, although that can be a thing. There can be, as I said, there can be parasites, there can be bacterial infections, there can be tick-borne infections.
Now, in relation to ERMI and HERTSMI, how much importance do you put on testing for ERMI and HERTSMI too in a home report?
Yeah, so I still think moisture mapping is one of the most important things to actually find the source. And then, whether you do air or you do surface testing or you do ERMI or HERTSMI, you want to then get a snapshot of what sort of species are in that building. Now, there are some theoretical advantages. So the ERMI is actually created by Stephen Vasper of the U.S. Environmental Protection Agency as a research tool. And it's based on PCR or DNA testing of mold in dust samples. And there's two ways of doing it. One is the Swiffer cloth method, where you just use a cloth according to their instructions and collect dust from various parts of a building, or the other way is using a vacuum cleaner. They seem to get reasonably similar outcomes. Now, the thing about it is actually country specific, and it even is condition specific. It's actually quite a sophisticated test where there's a group 1 molds and group 2 molds, and the final score is taken from a logarithmic analysis of the group 1 minus group 2, and then it gives you the score. So it very much depends on what the normal flora is in any particular country. And so the standard ERMI is based on the United States. Stephen Vasper has created one specific for asthma patients, but there hasn't been one created specific for CRS patients. But a lot of Dr. Shoemaker's research used the ERMI and then the HERTSMI, and they found that there were certain levels that were consistent with recovery and certain that weren't. I do believe that for accuracy, it would be most ideal to create an Australian-specific ERMI, because one of the problems I'm seeing is that there's certain molds are showing up time and time again in Australian ERMIs that make it look higher than it should be, in my opinion. Therefore, I think we are getting a fair degree of false positives on the ERMI, where someone has a reasonably high level, but their place doesn't have that many significant problems. So it is a very sensitive type of testing, and so air testing won't pick up some species, and I think particularly the Wallemia and the Stachybotrys are much harder to pick up on air samples, if I'm right. So you will get a more thorough picture, but again, is it too sensitive? So I think my suggestion is that if we can look at creating a Australian ERMI, so Finland has created one and Singapore has created one. Finland's actually quite advanced in terms of their understanding of mold, so they call it the Fermi, and Singapore calls it as the CERMI. So we have to think of another cool acronym.
Army, it'll be the Army.
Yeah, that's it. Yeah, that's it. That's funny. And so I think that would be the way forward. I think it needs to be corrected for the normal flora in Australia. And Stephen Vasper is very willing to work with us on that to create a Australian-specific ERMI, and I've been in contact with him.
So when you're looking at these ERMI tests, are you still saying, or have a benchmark as you go, no, that's too high, it's above 4, whatever it is, that's too high and you need to get more testing?
No, I don't use a specific number. No, I do on the HERTSMI. I do. The HERTSMI is basically you want to be less than 11. And a level of 15 or more is considered to be almost definitely contaminated. But often ERMIs, you'll see they'll often be in that 5 to 10 range quite often. And I think looking specifically at the Wallemia and the Stachybotrys and the Chitomium and Cladosporium and those, so it gives you a bit more